Hi everyone, and welcome back to another PS Platypus video. Today we're going to be looking at some physiology of the neurological system, and in particular the motor neurons as well as the control of movement around the body. So without any further ado, let's begin. As always, my notes are linked in the comments below, so if you'd like to check that out for any further information, please feel free to do that. So just starting off with the basics, we're going to be looking at the types of motor neurons as well as this thing called the homunculus man. So as you should know by now from the anatomy lectures, you will know that the motor system consists of a two motor system, essentially, two neuron system, which is the lower motor neurons and the upper motor neurons, as opposed to the sensory system, which is usually a three neuron system. So with the lower motor neurons, as you'd expect, they go from the spinal cord out to the muscle fibers. They're responsible for your voluntary and reflexive muscle motions, and the cell bodies are typically located within the ventral horn of the spinal cord, as you can see there. So alpha or lower motor neurons, the same thing. They have a bunch of inputs within this region. And again, it's not important to really understand this too much. I think the main ones to understand are going to be inputs from the spinal interneurons, which you might be aware is part of the reflex circuits or the reflex units. And you also have motor input from descending tracts. So remember that those are responsible for making sure that we're not having extended periods of stimulation of these particular fibers. So they're in a sense inhibitory. And you also have some sensory input from muscle spindles. So there's a lot of different things that regulate this. It's not just a very simple black and white system. With the upper motor neurons, it's a bit clearer. So it goes from the brain pathways into the ventral horn of the spinal cord, where it then synapses with lower motor neurons. It has an indirect role in controlling voluntary muscles because it then synapses onto the ones that have direct roles. The cell bodies are located in the motor cortices of the brain, and we'll discuss what the specific parts of the brain are in just a second. They descend mainly via the lateral corticospinal tract, but we know that there are multiple tracts responsible for motor control, which are covered in the anatomy lecture. And the basal ganglia and cerebellum are involved in ensuring that these processes are smooth. So we'll be covering those in a couple of slides' time. An important concept to be familiar with is this idea of a somatotopic organization. In other words, your brain has a mapping where you can sort of figure out, based on the region of the brain that might be affected or the region of the brain that we're looking at, what specific part of the body that's going to be controlling. Now, this is something that's not just unique to the motor system, it's there for the sensory system as well, which will be covered in a separate lecture. But in this case, it's called the homunculus man or the motor homunculus. So it's a coarse and non-specific innervation, which means that you do have some muscle groups that are going to be innervated by a region of the brain that is very close to each other. So in other words, adjacent muscle groups target adjacent regions of the body, but it's coarse. So what that means is if you hit or you stroke out one region of the particular brain, it's not just going to affect a very specific muscle, it's going to probably affect a lot of different muscle groups. So it's very coarse and non-specific. And the surface area that you see on the diagram there is proportional to the level of fine control. So if you have a look at that diagram, you can see that, for example, kind of focusing on this aspect, you can see hip and sort of legs, not as much control. But if you look at things like the hands and you look at regions of the face, you can see that we have a lot more fibers dedicated to ensuring finer control, which makes sense for things like facial expression as well as dexterity with the hands, not so much for the legs. And this is just a really funny diagram that shows how this would look if we were to blow up different parts of the body that had the most level of motor control. Okay, now there's a lot of descending motor tracts, again, as I mentioned in our anatomy lecture. This is just a summary from your lecture slides, and it's not really important for us in the physiology lectures to understand exactly how these work. I would recommend if you find this interesting, definitely look at the anatomy ones. But the main thing to understand here is that the lateral corticospinal tract takes up most of these motor neurons. So 80 to 90% from there. The medial would be the second most, so the remaining approximately 10 to 20. And then you have these smaller tracts that have some very specialized functions. If you take a cross section of the spinal cord, you will notice that on the left-hand side, we've highlighted the descending tracts, on the right-hand side, the ascending sensory tracts. We're going to focus on the motor ones. What's really interesting is that you have this unique arrangement of fibers. So firstly, if you look at the actual lateral corticospinal tract in the first place, within the white matter part, you can sort of see that from lateral to medial, or if you look from medial to lateral, you have a very interesting correspondence. You have most medial, or you could say closest to the gray matter, you have your cervical region. motor functions or motor muscles. Then you go thoracic, then you go lumbar, then you go sacral. In other words, from the top of the body to the bottom of the body, you have to go from medial to lateral within this tract. A unique sort of thing to remember is that this is kind of preserved as well for the sensory tracts, not so much in the sense that it follows the same order, but for example, if you look at the cervical fibers, they're the ones that are closest to the gray matter. Same with the sensory fibers, but it kind of goes in the opposite direction. So from lateral to medial instead of medial to lateral. But that's not really important for this particular lecture. If you then look at the actual gray matter itself, which is where you would find the bodies of the nuclei that are responsible for the lower motor neuron function. If you look at that particular aspect, you'll notice that the cell bodies that are more medial, oh sorry, more ventral would be responsible for your flexors, whereas the ones that are more dorsal would be responsible for extensor function. So again, a really, really interesting sort of idea to have in the back of your mind. Now let's go to the cortical regions. So you've got your, I kind of mentioned previously that you've got your primary motor cortex, which is the one that we all usually think about when we're talking about the motor functions or the main parts of the brain responsible for executing movement. But that's not the only region that we're actually interested in, and that's not the only input that we get. So obviously the most important one, we'll talk about area 4, so that's M1, primary motor cortex. It's only active when we're actually executing movement. So when we're in the middle of actually doing a movement, this is the part of the brain that's responsible. All your upper motor neurons pass through the corticospinal tracts, and then lower motor neurons go to the muscle fibers. It's responsible for simple movements. So if you have damage to the M1 region, you're probably only going to impact on very, very simple motions. It receives inputs from a bunch of regions, area 6, as well as somatosensory areas 1, 2, and 3. So the main thing to just remember here is that it's not just a unit working alone. It has to receive feedback, especially from sensory areas, to make sure that what it's doing is actually being executed in the real world. Now in area 6, which is, by the way, these areas that I'm talking about, they're according to this Brodmann classification, which you don't need to memorize anything about, but just note that area 6 contains the other aspects of motion or the motor control, which is the PMA and the SMA. So the premotor and the supplementary motor regions. And these are responsible for some complex motion. So if you have these being stroked out or having some sort of lesion, it will lead to apraxia, which is an inability to perform complex movements. So you've got the PMA, the premotor cortex, which integrates sensory information to guide movement. So it looks at what's happening around us and tells us, you know, the cup is this distance away, therefore you need to move your arm this amount, right? And then the SMA, the supplementary motor, it's responsible for planning actions from memory, as well as acquiring new sequences. So the classic question you'll get is someone rehearsing something from memory, or if they're essentially rehearsing any complex movement from essentially what they remember, you're going to be thinking this is an SMA type, SMA predominant action. And this region receives inputs from the posterior parietal cortex in the areas 5 and 7, as well as the prefrontal cortex. So again, a lot of that sensory information, but also some other motor regions. And you've got on the right-hand side the diagram of all of these. And you can sort of see the bottom diagram is not something you need to remember at all, but it's showing how complicated the communication between different parts of your brain is, just to get even simple movements or complex movements off just like plans, right? You need to be able to execute them effectively. Now, the reason why we're distinguishing between upper motor and lower motor neurons is because damage to either of these will lead to very, very, very different effects. So starting with the easiest one to kind of conceptualize, if you have damage to the lower motor neurons, you can imagine anything that if you kind of remove motor function from a muscle, what kind of effects is it going to have? Well, you're going to have flaccid paralysis, or you could say paraplegia, hemiplegia, depending on how many limbs are involved. But you essentially have a flaccid paralysis, which means your muscle essentially just goes limp, right? Because there is no motor innervation to it. So loss of motor control. You also get weakness, so paresis, like hemiparesis. That term specifically refers to one side of the body being affected, but paresis is just in general weakness. So you get an incomplete paralysis as well as hypotonia, so loss of tone. You can also get atrophy from disuse of a particular muscle, so that the fibers they reduce in signals, and therefore the contractile proteins, they're not being used at all, so they start to get degraded. You get areflexia as well, so essentially the branches that are responsible for allowing reflexes to occur, they're lost. So you might have the sensory pathway being preserved, but if you have no motor pathway, you'll not be able to see the reflex actually being initiated. And the interesting thing is, because you have a loss of these receptors, you have a loss of signals, what your body does is it thinks, oh my God, I'm not getting any signals anymore. I'll increase the amount of receptors that are being expressed on my muscle fibers in the hopes that even if a small signal gets through, that at least it'll be able to cause some contraction. And so even when very, very small signals will reach a muscle, you will get very rhythmic, but also inappropriate contractions of a muscle, which are known as fasciculations. So when you learn about the neurological examinations, I think you've already learned about this. You will know that in order to elicit fasciculations, you need to kind of tap on the specific muscle fibers, classically like the deltoid or the hamstrings or something. And that's to kind of give it a little bit of a signal, which will then lead to that inappropriate, exaggerated response within the muscle. So that's why you get fasciculations, whereas everything else sort of just makes sense, right? Weakness, atrophy, areflexia. Now, with upper motor neuron lesions, you get actually kind of the opposite of everything we just talked about in a sense. And the reason why is because remember the upper motor neuron lesions, they will, whenever you have a lesion within that region, you will also remove any inhibitory neurons that are going to fibers or muscles below the level of the lesion. So below the level of the lesion, you will have effects that are very reminiscent of actually increased motor functions because you now have loss of inhibition. Now, there is a bit more nuance to it. So immediately, so within the first day-ish of having some sort of lesion like a penetrating injury or a wound or a motor vehicle accident, you will experience spinal shock, which is kind of like a lower motor neuron lesion. And I like to just imagine this as your body thinking, oh my God, what just happened, right? And then it kind of just shuts down. So flaccidity, hypotonia, areflexia. So everything you see in the above row, you will see here. However, in the long term, so after the first day, leading into the weeks and months, the patient will slowly start to regain some function, but they've still lost that inhibitory effect, right? So you'll lose fine fractionated movements, but the general movements will tend to be okay. The most important thing is that you will have spasticity. So instead of being flaccid paralysis, where your muscles and your muscle groups are limp, you will have spastic paralysis, where your muscle groups don't move. But the reason why is because they're being stimulated so much that they become very rigid. And it's essentially a combination of two things, hyperreflexia and hypertonia. So before I move on to the next couple of dot points, I just want to take your attention to this right-hand side. Why do you get hyperreflexia? And it's because of that loss of descending pathway. So remember how reflexes work, right? A tendon hammer, when you hit a muscle, and I'm assuming that you're doing this in a clinical setting, you hit the muscle, it causes a reflex contraction. You have type 1A nerves that synapse onto inhibitory neurons to antagonize onto the antagonist muscle. So the antagonist muscle relaxes while the agonist muscle contracts. And that's why, for example, when you hit the hamstring, sorry, the quadriceps muscles, you get contraction of the quadriceps, but you get relaxation of the posterior group muscles in the thigh so that you can allow for that smooth movement. However, if you have upper motor neuron lesions, then that inhibition is lost. So inhibition to the antagonist muscle is lost, which means you get a very exaggerated and rhythmic motion, which if it's really bad can lead to something like clonus, which is essentially you hit the tendon once, but it just keeps doing that particular movement because it doesn't know when to stop. There's also this idea of a Jędrusik maneuver, which is not really that important for physiology. It's more for it's essentially more for clinical skill side. If you try and distract the patient, that can actually help to artificially heighten the reflexes. I'm not sure what the pathophysiology is behind this, but things you can do is to get them to interlock their hands together, or to look away, or to what else was there? I think that's it. There's also something else. Yeah, I've forgotten. But you try and distract them in a lot of different ways to be able to get that reflex to be a little bit better. Apart from that, you can have a positive Babinski reflex. So remember that reflex where if this was my foot, then you kind of take a sharp object and then you kind of roll it up. So with the sharp end, you roll it up their foot and kind of I guess you could say an upside down L shape almost. And normally in adult patients, you should see that their toes sort of curl inwards, right? So they curl towards the plantar aspect of the foot. In babies, if you do this, it kind of goes backwards. So you get it going sort of upwards like this. And that's normal in babies, but if you see that in an adult, that means you've lost some fibers of the corticospinal tract, and you start to get these um, previously sort of abnormal, or I guess you could say, you get pathological re-emergence of some of these reflexes that would have been normal in childhood, but would have gradually be lost in adulthood. So you get dorsiflexion of the big toe and fanning of all of the other toes. So it kind of just goes backwards and it fans out like this. You can also get wasting in this situation as well, but mostly again because of disuse, because you get weakness of the muscles in the long term. So basically, if you find this really difficult to remember, which I did when I was back in your position, the way that I would remember it is that upper motor neuron lesions lead to everything going up. So reflexes go up, tone goes up, and also the big toe with the Babinski reflex goes upwards, right? It goes kind of up rather than going downwards towards the ground. Okay, now the cortex is not the cerebral cortex is not the only thing that's responsible for movement, because if the cerebral cortex was the only thing acting, it would kind of be giving these signals in a very jutted movements, right? And you need some, I guess you could say, middlemen to be able to get this signal to be smoother than it normally would be. So uh, those centers are going to be the cerebellum as well as the basal ganglia. So the cerebellum is an important organ or an important part of the CNS, because while it composes only 10% of the mass, it contains half of the total neurons. So obviously there's a lot of inputs and outputs coming in and out of this particular part of the CNS. And it's responsible for refining movements, but it doesn't actually directly target the lower motor neurons. Some of the major functions it has is to allow for balance, posture, coordination, motor learning, and some elements of cognition. And just a general rule, the cerebellum controls movements on the ipsilateral side of that particular lobe of the cerebellum. Okay, so that's just an important rule to keep in mind. And again, in the anatomy lectures, I would have gone through some of the tracts that come out of the cerebellum, or essentially, sorry, go towards the cerebellum. And you'll know that regardless of how many times it crosses over, it'll always end up on the cerebellar lobe that is on the same side as where it originated on the body. That's just something to keep in mind. So how does it start? You get some neurons within the cortex. So you can see over here, you've got neuronal bodies, cell bodies in the cortex that project deep nuclei within the cerebellum. Awesome. Those deep nuclei go to the contralateral brainstem nuclei. So they go to these nuclei here, and then they on the other side, and then travel upwards towards the motor cortex. So essentially, if you want to simplify it from the cerebellum, they decussate, so cross over, and they go to the contralateral cortex. Then from there, they go back down. So they go down, decussate before descending towards the spinal cord. So they've gone down again to the spinal cord and then towards the muscles. So essentially, they do, yes, decussate above the level of the cerebellum. But once you get down here, you can, if you just ignore this part up here, you can kind of imagine that it just starts here and then goes down here. But of course, it does need to go to the cortex to be able to refine whatever output the cortex gives and says, I want you to do this. The cerebellum will always be like, okay, no, we have to make sure this is proper before we send it down to the spinal cord. So that's why once you have the double decussation, for example, if you have a left cerebellar issue, it will always affect the left side. Whereas if you have a cerebral damage, so if you have damage to this part of the motor cortex, it will actually affect the opposite side of the body. And I guess now you can see why, based on the arrangement of neurons within this particular diagram. Now, there are different divisions of the cerebellum, and I think it's more important here than in anatomy to really understand what the differences are. So there are three main functional divisions, and I'll also kind of talk about their corresponding anatomical divisions. So the vestibulocerebellum, as the name suggests, is mostly responsible for balance and gait, but also for some ocular movements. And this is mainly going to be the flocculonodular lobe. So this bit at the bottom. Okay, that's going to be the vestibulocerebellum. The inputs of this are going to be the vestibular system, superior colliculus, which is responsible for getting inputs from the eyes, as well as the visual cortices. The inputs are mainly from the midline receptors in the head, neck, and trunk that are the vestibular systems. And they also it's mainly going to receive vestibular and proprioceptive information. And essentially, the main function it does it compensates for shifts in body position. For example, in the gait cycle, you can't be consciously thinking about exactly how you want to compensate for the fact that my leg is now going forward on the left hand side, so I need to move some weight over to the other side to make sure I don't fall over. You can't be thinking about that every time you walk. So this part of the cerebellum is responsible for making sure that it is kind of given to a subconscious aspect of your mind, so you're not having to think about it. So that's why if you have lesions in the vestibular cerebellum, it leads toward difficulties in maintaining your normal balance. So in this GIF here, you can sort of see that the patient has problems with when they every time they walk, you kind of lean towards the side that you put your foot outwards to, because you don't like your brain is not able to figure out how to recompensate the weight to be able to shift and prevent you from falling. So you can kind of see anytime this man puts his left foot forward, he leans over to the other side to try and balance it, and he has to think about this consciously to prevent himself from falling over. Additionally, in these patients, you can also have nystagmus and other problems with the eyes because of the additional functions of the vestibulocerebellum. With the spinocerebellum, this is mainly the vermis and the intermediate hemispheres. So essentially, this really deep blue color in the middle, that's going to be the spinocerebellum. And it's really easy to remember because it's kind of like the spine of the cerebellum, right? It's right in the midline. And the main function of this is control of any current ongoing movements within the limbs. So it's mainly going to receive sensory inputs from the spinal cord and the contralateral motor cortex, as we sort of discussed in the previous slide. And it checks essentially if the movements that are already happening are actually going as planned. So it looks at the movements and makes sure that we're actually doing it properly. So as you would expect, if you have a lesion, you would expect there to be problems in smooth controlling motions. So there's a lot of terms that you can use to describe these problems. So ataxia refers to uncoordinated velocity dependent movements that are affected. Dysynergia is decomposition of synergistic multi-joint movements. Dysmetria, dysynergia is like, complex movements that decompose and they're not able to actually do them all together. Dysmetria is lower coordination, so it leads to things like undershooting and overshooting. So if you do these sorts of tests on a patient, so like ballistic tracking type tests in clinical skills examinations, in this patient, you can sort of see that they either undershoot and they're a bit wary of hitting the pen, or sometimes in some patients, you'll see that they kind of go past it and then kind of bring themselves back because they're not able to assess the depth and then execute the motion. They can also have issues like dysdiadochonesia. So remember, when you do rapid alternating movements, like sort of this motion, they can kind of break down because it's a form of dysynergia. And you can also have intention tremor. So when they're trying to reach for something, so in this patient, you can have a situation where they're leaning forward and then their hand sort of just like breaks down because they're trying to approach, but their body's not letting them perform the complicated movement that they're trying to think of. And finally, you have the cerebrocerebellum. So everything that remains, it's mainly the lateral hemispheres, so on either side. And the major function is planning, modifying, and learning repeated movements. So it receives motor and sensory information from the contralateral cortex, as we discussed previously. It's mainly involved with trial and error learning, especially with fine motor skills. And so when you have a lesion, it causes problem with motor memory and some cognitive functions. So motor things like delayed initiation, irregular timing of movements, and cognitive being things like spatial, affect, abstract reasoning, and other. So you can see that not all of these things are like motor related per se, but I think for the physiology lectures in this case, I think it's more important to talk about the motor sides because there's going to be, all these organs have a variety of functions, but we're mainly focused on localizing symptoms. So if you see symptoms like this, you can suspect a cerebellar issue. Now, I think it's the most high yield thing. If you don't remember anything about the cerebellum, totally fine. I would understand. But with the basal ganglia, I think this is probably the highest yield, not only in this context for physiology, but also for your pharmacology. And when we talk about treatments for things like Parkinson's and so on. So what is the basal ganglia? It is a skeletal-muscular circuit that exists between the cortex and the thalamus. So in other words, it's responsible for, again, refining movements that we're generating within the cortex. And there are four major nuclei that you need to be familiar with. So the GPE and the GPI are the globus pallidus external and globus pallidus internal. And again, there's a diagram here that shows all of the different structures labeled out. But once we get to anatomy, you'll be able to you'll be able to identify this more in cross-sectional imaging. Over here, it's just important to remember the names and how they're arranged. You also have the SNC and SNR, so the substantia nigra pars compacta, and also the reticulata. Remember this in particular, especially the SNC when we discuss pathologies like in Parkinson's. The STN is a subthalamic nuclei, which is, as the name suggests, underneath the thalamus. And the striatum is a combined structure that actually consists of the caudate nucleus and the putamen. So these are the four major nuclei that you just need to have an idea about what their acronyms correspond to. Also, something that's not really part of the basal ganglia, but it's actually still part of the circuits, is the VLO, or the ventrolateral nucleus pars oralis, which is found in the thalamus. So technically not part of the basal ganglia, but it's still important to know the VLO because it has a function. And that function is essentially the direct pathway and the indirect pathway within the basal ganglia circuits. So again, just to keep it really simple at this moment, remember that the direct pathway is responsible for facilitating motor effects. So it helps you to perform motion, whereas the indirect pathway is suppression. So it tries to reduce the amount of movement that you're able to do. When we get into the details though, I guess this diagram on the very right-hand side is probably the best thing. If you have a couple of minutes, I would recommend drawing this out a couple of times so that you can remember how the circuits work. Because there's a lot of positive feedback and there's a lot of negative feedback happening. But I guess you just need to remember exactly which steps are positive and which are negative, or excitatory and inhibitory. So I've tried to simplify it a lot with these small things here. So in the direct pathway, which is on the left-hand side here, the cortex sends a signal to the striatum, which is a positive one. So the striatum is activated. It actually decreases the net effects of the GPI, so the globus pallidus internal, as well as the substantia nigra pars reticulata. So this is a combined system. So it reduces that signal from here. And essentially this system is responsible for keeping the VLO in check. So I kind of like to think about this backwards. So the VLO, think about that as being like this really excited puppy that's trying to push the cortex to kind of initiate movements. So it's really it's kind of hyping up the cortex and saying, just do what you want to do, right? The cortex is like, yeah, I want to move the arm. VLO is like, yeah, just do it, whatever, right? So that's the VLO. The GPI SNR is responsible for keeping it sort of calmed down. So keep this hype man from causing too much motion. But in this case, the striatum is telling this regulator to slow down and saying, it's okay. Let the VLO do its work. Let the VLO hype up the cortex. Just let this motion go through, because I think that this particular movement is okay. Like it's an appropriate movement. So that in total, you get a positive effect. And if you're like a maths person or something, you can even just look at the fact that you've got like the number of inhibitions and the number of excitations, you've got more excitations, and therefore you have a net excitation effect. Now with the indirect pathway, it's a little bit more tricky. So instead of going from the striatum straight to the GPI SNR system, we're going to go along a different pathway, which actually involves the GPE. GPE, then to the subthalamic nuclei, and then down to this particular system. So again, you have a very similar process, but you can sort of see now that we're not reducing the signals coming out of the GPI. We're not slowing down the GPI SNR with this red arrow. We are now actually allowing the GPI SNR to continue its regulatory role of the VLO and telling the VLO to chill out. We don't want the cortex to be excited, so I want you to go to sleep, and tell the cortex not to continue what it's planning on doing. But it follows this kind of more complicated side branch, which is still important to remember, but it's the main thing to note is that it's actually going to do the opposite effect. So you can imagine that if you need to have like a balance between these two things. So you want to make sure that not all of the movements that your cortex thinks of go ahead, but you also want to make sure that there are still the important movements that the cortex needs to do and that the whole body agrees is important that are allowed to go ahead. So this is like a filtration system in a sense, and that balance is very important. And how does dopamine play into this? So note that neurons within the striatum, so remember the striatum is the caudate nucleus as well as the putamen, they contain D1 and D2 dopamine receptors. Now the D1 are essentially present in neurons that enter into the GPI pathway. So it's going to be the direct pathway, so net facilitation. And the D2 receptors are going to be present on neurons that enter the GPE. Those are mainly going to be the indirect pathway, so net slowing down of motor functions. So the D1 receptors are actually excited by dopamine, but D2 receptors are inhibited, which means dopamine is released from the SNC, so substantia nigra compacta. That means if dopamine is present, you have more D1 effects than D2 effects. So you actually get more of the direct pathway happening, which makes sense because D1 is expressed in the direct pathway. So it has a net facilitatory effect on movement selection and initiation. So in other words, to keep it really simple, more dopamine means more movement. Okay, and it's because it's mainly in the direct pathway. And the other important thing is the fact that dopamine is made in the substantia nigra compacta, because this is where the primary pathology we're going to talk about later is going to occur. Now, just to keep it very broad, firstly, the basal ganglia is not just all about, it's not always going to be perfect. There are going to be instances where you either have damage to a neuronal group, for example, ones that create dopamine, or you have other causes that lead to an imbalance between excitation and inhibition. So you either have too much or too little signals. So that leads to two types of disorders: hypokinetic, which is when the indirect pathway is stronger or the direct pathway is weaker. That's classic in a condition like Parkinson's disease. So that can lead to achynesias, impaired motor initiation, and bradykinesia, or slowed motor movement. Hyperkinetic disorders are also common, but we're not going to talk about them too much. They're when the direct pathway overcomes the indirect pathway, and it's typical in a condition called Huntington's disease, which leads to dyskinesias or involuntary movements, hypotonia, and other things like chorias, hemibolismus, athetosis, which are all different terms that describe similar events where your body has uncontrolled movements. But I've kind of included a little diagram here to show the difference between all these terms. It's not really important to know the difference, but they all have clinically different presentations. Now let's talk about the most important pathology when it comes to basal ganglia, which is Parkinson's disease. So Parkinson's disease results from less levels of dopamine. And this you can kind of see on a pathology specimen. These are mostly post-mortem. So usually, I know it's a bit morbid, but usually the definitive diagnosis of Parkinson's is only made once we have an autopsy of the patient and we can actually see these reduced levels of darkness within the SNC, or the substantia nigra pars compacta, which represents a reduction in the levels of the dopaminergic neurons, which normally pigment in this kind of dark color. So this is the normal patient. This is the abnormal, where you get less of that darkness. The early symptoms tend to be motor related, and the nice mnemonic to remember this is TRAP. So tremor, which is classically a pill rolling tremor. So you see patients sort of doing this as if they're rolling pills. It's maximal at rest. So if they're not moving, you can see that tremor. And it's less if they're focused or they're trying to do something with their hands. R is for rigidity, so joint stiffness increased in muscular tone. A is akinesia or bradykinesia, so either no movement at all or slowed motion, more likely to be bradykinesia than akinesias. P is postural instability, because now, of course, remember that these parts of the brain are also responsible for refining balance, right? So you get postural reflexes that you and I, normally we don't have to think about how we posture ourselves, especially when we're moving around. But in these patients, that reflex is not refined anymore. So it leads to a lot of instability, so increased risk of falls. Other effects are usually non-motor. So because of the non-motor functions of the basal ganglia, so autonomics, cognition, behavior, sensory, sleep, and so on. And also there's this pathological reflex that you can elicit in patients with Parkinson's called the glabella tap, which is when you tap on their forehead, the glabella, it causes a blinking in their eyes because of the fact that they're kind of not able to slow down their blinking. So it just keeps going. And it's, again, like the Babinski reflex, it's because of reactivation of a primitive reflex that you see in babies. So how do you treat Parkinson's? We don't really go into the pharmacology too much here. There's a whole lecture on that if you're interested. But remember, the main kind of first-line medication tends to be levodopa, which is a precursor to dopamine. And that makes perfect sense now because we know that the primary pathology is less dopamine. However, we can't give dopamine by itself or alone, right? Because we know that it cannot cross the blood-brain barrier. So we need to give the precursor, which can cross, and then it gets converted into dopamine by particular enzymes. However, it can still cause peripheral effects if some of that levodopa stays within the peripheral system, and it can also lead to desensitization over time. So it's not a perfect drug, but it can still manage the major symptoms that you see. Other drugs include agonists and drugs that reduce dopamine reuptake. Surgery is also an option if the pharmacological aspect is not working very well or they've become desensitized to it. And you can, in particular, make lesions within the subthalamic nucleus or sometimes in the GPI. And that reduces the indirect pathway essentially to allow for more direct pathway responses. but that can still lead to hyperkinesia. So if you, obviously these are not perfect procedures, so you can get some of the opposite effect happening if you try too much, right, to remove that brain tissue. The other interesting thing you can do is deep brain stimulation. And this sometimes, a lot of people think this is like the last resort, right? But if sometimes if patients want this, this can actually be a really, really like life-saving procedure. If you actually look up a video of how the deep brain stimulation works, some people have it sort of, obviously they have it implanted within them, but they have like a little remote that they can use. And sometimes you can see when patients shut off the deep brain stimulator, you can see like instantly kind of how the effects of Parkinson's disease start to come back. And then as soon as they turn it on, they're kind of back to normal. So it's a really remarkable piece of technology and essentially allows for stimulation that inhibits the STN and the GPI whenever it's most required. So when they get exacerbations of their Parkinson's disease, too much tremors and they feel like they're going to fall, then starting this deep brain stimulation can be super duper helpful and sometimes life-saving. So that's pretty much it for this particular lecture. We've covered essentially the major parts of the motor system, as well as these two different systems within the cerebellum and the basal ganglia circuits that actually help to make sure that the motor inputs and outputs are all going to be correct and appropriate. I think the most important things to understand are going to be the basal ganglia circuits, the parts of the brain that we get the cortices for motor control, as well as just the major functions of each of the three functional divisions of the cerebellum. If you know all three of those, that will go a long way for this physiology lecture, and essentially all you need to know for this particular topic. So hope that was okay. Hope that wasn't too confusing. As always, feel free to send me any messages if you have questions. Best of luck for your future lectures, any assessments, any exams that are happening, and I will see you in another lecture. Till then, bye.